I've added some new slides to some interesting ideas that we've had for a couple of years, so I won't delay, and we'll use about 50 minutes for the talk and about 10 minutes for the question and answer, more or less. Before I start, new news. If you haven't seen this, oh my gosh. So the CMS came out with a memorandum for acupuncture coverage for chronic low back pain unexpectedly. And you can see it's up to 20 visits in 90 days are covered by Medicare beneficiaries with different circumstances. And those are still to be worked out and such. But amazing that CMS will cover acupuncture in certain circumstances in healthcare systems. Again, brand new news, just came out 2 days ago. Quite exciting. So I'm going to talk today about pain, which has been my focus for the last number of years. And some of these are known numbers to you. The next slide is going to be the more depressing slide, if that's possible. Pain affects 100 million adults in the US, and again, both chronic and acute pain. So again, it's a very important condition. Again, this is a little bit old, but the costs, I think, are pretty underestimated at $560 to $635 billion annually. I think it's increasingly higher. This is from 2012. So again, I expect it's going to be maybe over $1 trillion per year, which is, really sad. Pain is a public health problem. A lot of issues with the disability, issues with quality of life and productivity, diminishing all of those. And in 2012, and again, there's some new data coming out soon, 50 times more prescriptions in the US and the rest of the world combined. So again, we've all heard about the opioid epidemic. A couple of new numbers that came out just recently. Average 130 deaths daily from opioid overdose. And they break that out into the line number 2, which is heroin, which is 15,000 deaths. And then synthetic opioids, other than methadone, 32,000 for a total of 47,000, which ends up being a little over 130 per day. Again, this is brand new data coming from the National Center for Healthcare Statistics. That's actually based on provisional data, but they're pretty accurate. The misuse of opioids, $10.3 million people in 2018. 2 million misused opioids for the first time in 2018. 2 million people had an opioid use disorder in 2018. 81,000 used heroin for the first time in that same year. And then 108,000 people used heroin. So again, there's been so many efforts on appropriate prescribing and reducing and all these different aspects. And the current data suggests there's a mitigation in certain circumstances of opioid use and misuse, but these numbers are still outrageous. And again, what can we do to help? So I'm going to pivot now to the National Center for Complementary Integrative Health, the range of research question, which I think is a really nice tool. This is a couple years old. I'll show you a more recent one coming up in a minute though. But it really gives us a sense of, when we look at research, we're looking at basic science, oftentimes animal research, where we ask, how does it work? Then it goes to translational research. Can it be studied in people? What are the specific effects with efficacy trials, including RCTs, randomized controlled trials? And then finally, outcomes and effectiveness research. How well does it work in the real world settings? And I'll focus a lot of my talk, in fact, most of my talk, on this red bubble over here on the right. But one of the things that you have to have before you can actually go to the red bubble is efficacy trials, where you have to see in randomized trials that a certain intervention has been efficacious. So for example, acupuncture after knee osteoarthritis has been studied in a number of randomized trials. Then we actually can look in the real world and see if acupuncture is provided in real time, what we're seeing for patients. So they're reporting less pain, less opioid use, maybe being discharged from the hospital several hours earlier. So again, efficacy comes before effectiveness in this kind of figure. I moved this to the front of my talk. This is actually something why we're here. This is a study that was done, or an evaluation of 105 randomized trials from many members of NCCIH. And they looked at 105 randomized trials, and they actually looked at positive and negative effects and came up with that acupuncture was generally positive for back pain, osteoarthritis of the knee, whereas massage therapy was positive for neck pain and back pain. However, that these little A's mean that it's weaker evidence. So massage therapy for back pain was a bit weaker than other areas. Osteopathic manipulation, back pain, relaxation techniques, severe headaches, migraines, and fibromyalgia. Spinal manipulation, back pain, Tai Chi, osteoarthritis of the knee, fibromyalgia, and yoga for back pain. And what was more interesting actually than this was there was an accompanying in JAMA no less, in the midst of the opioid epidemic, or our awareness of it perhaps, about how complementary therapies can help to gain traction. And what I'm going to point out today is, in this particular, these next two slides, is the NCCIH team had some comments, and we don't always get these in our academic papers. We are very prescriptive. We have a abstract, introduction, methods, results, and discussion. And this is actually an interesting area where we're getting some quotes from some of the authors. So in this case, the systematic review was just looking for positive and negative. So this Richard Nahan was the key author on this. And he said over here, based on the preponderance of positive versus negative trials, complementary approaches that offer pain relief include acupuncture and yoga for back pain, acupuncture and Tai Chi for osteoarthritis of the knee, massage therapy for neck pain, and relaxation techniques for severe headaches and migraines. I just showed you that a second ago. But interestingly enough, what he then says is, when you look beyond RCTs, Nahan noted that clinical trials met the bar, that clinical trials that met the bar for review tend to be small. Participants were limited to older white women. And the quote is, the review identified a lot of gaps in the data, he said, adding that there's still a lot of research that needs to be done to see whether these data can be generalized to a larger US demographic population. David Chertoff, who is the deputy director at NCCH, went on to say that they're looking to conduct pragmatic studies to look at the effectiveness of complementary health strategies for pain outside of the strict inclusion-exclusion criteria of RCTs. Quote, we're looking to see how this works in real time in the real world with all the warts and things that go along with that. Finish the quote, Richard Nahan said, at the end of the day, if an approach is successful, you'll be able to generalize it to more everyone with a disease versus a very small cohort of individuals. Now, what these two comments point out is randomized controlled trials, albeit important, albeit I'll leave it at the gold standard, are limited in that they have strict inclusion criteria where you might have 100 people who are interested in your study and maybe 10 meet the criteria. So we end up studying smaller groups of people that might have no limitations with time. They can come to the clinic whenever we want to see them. They may be able to come to the lab. So the point is, randomized controlled trials are an important consideration, but it doesn't help indicate how these therapies or interventions can be best utilized in the real world. And I don't know about you, but I live in the real world. So again, where a randomized controlled trial says something, I take it as an important consideration, but then I wonder, how do I apply it to my real life? And our patients do the same thing. So again, if I look to now this new updated figure, again, pragmatic trials are where NCCIH is very interested. Again, is it still effective when implemented in real world conditions? So again, just an update on their range of questions, but the same general trajectory of how we look at basic science up to pragmatic studies. Here's now I'm going to pivot now to the fun part, as I'll say, of the lecture, is these same buckets: basic science, efficacy trials of clinical research, and then clinical practice. And what I'm going to focus on today is practice-based research, which is this, what I call a T2 translation between bedside and practice. Because let's face it, randomized controlled trials do not provide clinicians with a cookbook, let's say, for how to provide therapies to patients, or the amount of therapies, the right therapy. So we might say that 8 weeks of acupuncture helps with knee osteoarthritis. The trouble is our patients can't come to the acupuncturist 8 weeks in a row. They have scheduling issues. They may not be able to pay for acupuncture 8 weeks in a row. So again, all these different aspects impede the ability of randomized controlled trials to impact clinical practice, which our goal is delivery of the recommended care to the right patient at the right time. And that's actually what's challenging from randomized trials. What we do have, however, is practice-based research. This is where information is gathered from clinics, usually primary care clinics or integrative medicine clinics in this case, and we look to collect the information as it's happening in real time. out of the confines of randomized controlled trials. So very few inclusion criteria, if any, and the applicability and generalizability is more enhanced. So what is practice-based research? So research that generally occurs in the office, clinic, hospital, where patients generally receive clinical care. Makes sense. It's a method to study interventions as they routinely delivered clinically. Routine is the key word there. This is not a preordained set of visits. Now, again, if your clinic says every low back pain patient gets 6 visits, that would be routine for your care, for your clinic. In most cases, I see, in my experience, a more heterogeneous delivery. Namely, the scheduler plays a big role in when patients come back, and the patients oftentimes cancel. So again, it's not this consistent dosing that we see in most randomized trials. The advantages, you can examine whether interventions with proven efficacy, so again, we have to have trials to get to this point, are truly effective and substantial when provided in a real-world setting. It captures data on representative patients who are receiving representative treatment. So again, this is the real patient receiving real treatments every other week, every third week, twice in 1 week, based on their schedules and their ability to pay. It's possible to assess the utility of an intervention provided by clinicians with a broad range of training and expertise. So again, you have residents up to attendings in some cases. It's possible to obtain clinically detailed patient-level information, ICD-9 codes, 10 codes, whatever it's going to be. You can get problem lists. All this can happen with practice-based research. The disadvantage of obviously causality. We're not randomizing, so again, we look for associations with receiving certain treatments and outcomes. The data collection may not be performed by researchers, might be by clinicians who lack specialized research training. One of my additions is the electronic health record is a clinical tool and not designed for research purposes. I almost should have a tattoo on my arm that says that, because I will give talks like this and people will say, oh, we've got electronic health record, it's all in there. And I have to caution them that it may all be in there, but can you get it out and can you make sense of it? And so it's a clinical tool in general, and for research purposes, we have to do some work to design the electronic health record data collection efficiently to meet our research goals, or have ways to cultivate that information out of the record, which is not always easy. And lastly, a new addition is patients may receive different durations of treatment influenced by factors such as insurance. So in some cases in our integrative medicine clinics, patients are reimbursed by their insurance company for being seen, or I guess the clinics are reimbursed, excuse me. In some cases self-pay. So again, the factors by which patients are able to see us and the number of times they see us can be influenced by other things other than their ailment. I'll give you 2 examples of the current state of practice-based research, and then I will get to some of the future state. This is just to remind me that I had an R01 that was looking to study integrative therapies as delivered at the bedside when I was at Allina Health at Northwestern Hospital. And we had 3 aims. And again, it was very unique to get an observational study funded by NIH. I would gather that maybe 5 to 7% of NIH is funding things outside of randomized controlled trials. A lot of it's basic science. We're looking for mechanisms, and very little of it is real-world explorations of outcomes. However, there's a new move towards pragmatic research from NCCIH and others. We have the NIH Collaboratory, so they're making movements to really understand what happens in the real world. In this case, the R01 had 3 aims: understand who was selected for integrative therapies, examine the pre-post changes of outcomes in pain, of course, and again, the duration of pain relief, because one of the things our prior work had shown, we saw about 1.9 unit difference on a 0 to 10 pain scale, where 0 is no pain and 10 is maximal pain. The average was about 4, and it went down to about 2, roughly 2 units. And the question that we had clinicians ask us consistently was, that's well and good, Jeff, but after 45 minutes, you have a 2 unit difference. How about 4 hours later? How about in the middle of the night? Can you tell us more about the duration of pain management? And that we thought was actually very helpful to figure out the impact, both acutely, which is the 45 minutes, but also a little longer duration. This is, in this case, up to 5 hours. Before I get to that, I just want to let you know, I'll go over this quite briefly, but we did a cost analysis and published this about 2 years ago in JACA, and it was with 2,700 patients who received IM for pain and met some eligibility criteria. And it was very limited eligibility criteria, which I will not go into, but you can read the paper if you like. And we used regression techniques to look at change in pain, length of stay, the APR-DRG, which is really a severity code, with changes in pain on the total cost for the hospital admission. I highlight the word cost here because oftentimes systems will let you have the charges, and the charges are not necessarily based on reality. There are always these reductions that insurance companies require, discounts, so the charges are elevated and they're discounted. We actually were able to get the cost, real cost for the hospital admission. And what we found was the pain was reduced by an average of 2.05 units. And we put that into our regression. We were able to deduce that the pain reduction itself was associated with a cost savings of roughly $900 per hospital admission, which, in all caveats, this did not take into account the delivery of the integrative therapies. And on average, everyone had about 1.5 units of service. So again, 895 or 898, excuse me, divided by $100, $150, that's still a pretty decent ROI. Namely, we're looking at $900 in a cost of system, roughly $150 to deliver that service. So again, this is something that speaks to the idea there can be some cost savings via reducing pain in the acute care setting. I'm going to show you now some slides that we're still working on the paper. So this is actually fun for you to see, hopefully. We actually collected pain scores up to 5 hours, excuse me, after the patient received integrative therapy. So this is an individual on my team. He's got a tablet here. We would get a call from the provider saying, hey, I had someone who had pain, and we would then go to their room within 30 minutes of the end of the integrative medicine visit to enroll them in a study, a longitudinal study to collect pain scores from 30 minutes up to 5 hours. In this case, the IRB allowed us to blind the patient to hypothesis. In this case, this team was identified as the Abbott Northwestern pain team, not the Abbott Northwestern integrative medicine pain team. So in this case, we were trying to collect information from the patient and not alert them that we were following up on the treatment they had just received. In this case, what I'm showing you here is pre-score, post-score, 30 minutes up to 5 hours. We've got different clinical populations, and we've got different categories of pre-scores and post-scores. This is to remind me to mention that the provider, actually the acupuncturist, the massage therapist, the music therapist, collected the pre-scores and the post-scores. And this is roughly about a 2-unit decrease in pain, which, by the way, is, according to some studies, where the minimal important difference is in pain relief. Namely, pain medications provide about a 2-unit decrease in pain. So in this case, we've controlled for all the pain medications. You can't see going up to like 12 hours beforehand. So our goal here is to not take credit for someone getting a Dilaudid 5 minutes before they're seen by the integrative provider. So we've controlled for all the pain medications, both dose delivery and expected duration. So this is actually, we're looking at the integrative medicine relief of pain. And we're seeing actually pretty nice deltas pre and post. Now, the worry is, does that go back up to baseline? So for example, in this case, the baseline is roughly 3.5, goes down to 1.5. The expectation of, if this is simply that the patient is responding to the provider and is being nice, we'd expect that score to go back up. Namely, I received an acupuncture session, you were nice, it'll be back to 3.5 when you're gone and the pain team is asking the questions. So what do we see? So that was the question, is what number one is, will there be an exaggeration of the pain relief? And will that pain relief in fact be consistent over 5 hours? So I've broken this out. This is the research assistant collected data, 30 minutes up to 5 hours. This is for a mother-baby unit, OBGYN. And you actually see, this is oftentimes not in the midst of labor, because that's really hard to get into that environment. So this is where people are coming in for prenatal issues, and they're an inpatient, and oftentimes for stress and for pain conditions. So in this case, they're 3.5, goes to 1.5, and roughly 2 for the next 5 hours. And we're looking at, probably across all of these, I left off the ends just because we're working on that for the paper, roughly in the tune of 750 to 1,000 and per cell, or per population. Cardiovascular oncology, same thing. We're seeing the decrease, a bit of a bump up at 30 minutes, but pretty flat up through 5 hours. All other, which are abdominal surgeries, it might be appendicitis, whatever it's going to be, up, flat across for 5 hours. Orthopedics and spine, clearly highest pain scores of all, and there's relief, which lasts up to 5 hours. And every one of these numbers is below their baseline. So again, while there may be a slight exaggeration of the provider, the patient providing to the provider a better score than perhaps they feel, we feel like all these scores from 3 hours to 5 hours are well below where they were at baseline, indicating controlling for medications, controlling for dose delivery and method, there is a benefit to patients for receiving integrative therapies in the hospital. This is an article in preparation. I'm going to pivot now. We received a supplement to the R01 to test out the concept, could we provide delivery of acupuncture in the ED? Now, this is not the ED, this is lovely. It's a spacious, relaxed outpatient clinic with quiet instrumental music, softly lit, pleasant spelling. Now, the ED is cramped, stressful, loudly beeping, sometimes screaming, depending on if the behavioral health people are around where you are. It's brightly lit, fluorescent lights are the norm, and offensive smelling, and we all know what that means. So again, acupuncture works well here. We know that from a number of studies. Does it work well here? So briefly, what we did is we simply deployed the acupuncturist into the environment and paired him with the providers. These are MDs, NPs, or PAs who were in that environment who could refer for acupuncture. And so the MD played a critical role, or the providers played a critical role in this. So our first question was, would this team, and I just used MDs in the shorthand because there are more of them in an environment, would they refer? And in fact, yes, 73% provide at least one referral for acupuncture in the 13-month window of the study. And the study was simply seeing, was acupuncture acceptable, and what were the outcomes for the pain outcomes. The bigger question, actually, or equally big, was would patients accept acupuncture? And despite what we all believe, people weren't going to the ED for acupuncture. In fact, they didn't really know it existed. They were unaware. We did not notify the news media. We were very quiet, ran the study just for people who were coming into the clinic or the ED. 89% of the people who had received a referral accepted, so 248 out of 279. Would acupuncture provide pain relief? Now, of the 248, not all people are able to provide post-pain scores. They went to testing, they went to other areas. So we had 182 people who gave us both pre-scores and post-scores. And 49% had received some pain medication before coming to the hospital and acupuncture. And so they had a 6.88 on a pre-scale and a decrease of 2.68 units. 51% had received no pain medications and 6.71 on the pre-pain score and a change of 2.37 units. Now, the focus was not to compare these two because that was not the intent. The intent was to see what the acceptability would be and what the outcomes would be. Very suggestive that we were very excited because both groups actually had a 2-point unit decrease, which was clinically significant. Both received acupuncture, so there was really no comparison, but we were actually happy to see that the no pain medications before did as well as the people who received pain medications. And then subsequent to this, was there any effect on pain medication usage after the ED stay? In fact, yes. 62% were discharged from the ED without any additional pain medications. And 25% received an opioid and 13 received a NSAID. We published that a couple of years ago. Issues with this, again, any observational work, there's no control group. The acupuncturist was involved in the data collection. Patients were referred to acupuncture by the physicians. So we did a pilot RCT, which I'll just briefly go into, just because the point is that observational data can lead to clinical practice, or it can lead to actually follow-ups of research that include a randomized controlled trial. So we actually abide by that in our doing. So again, this practice-based research, you can go back and do a feasibility study to see if, in fact, were we seeing something that was actually real. I'm going to skip over this, but this just talks about all the things you do in randomized trials that change the reality. We did have a study nurse that screened everyone at the triage desk. We got the provider, provider assessed eligibility, and then we had acupuncture group and usual care group. Take-home messages. We had some eligibility where we looked at higher pain individuals. They have 4 or higher in pain. And 78% of the people that we approached, only 59 in this case, it was a very short study, 46 enrolled. Subjects were then randomized to acupuncture or usual care. Average age was 36. Most were female, most were non-white. This was actually pretty interesting because it was very different than most of our clinical trials in integrative health and medicine. Because of being in the ED, we really were able to get a more heterogeneous group based on racial characteristics. In brief, pain scores were high, 8.8 to begin. The difference was a 3-unit difference, a 3-unit decrease at post-pain score about 45 minutes later. At ED discharge, went down to 2.71 units, and in 30 days, we had a 30-day call, it was down 5 units. Usual care group, 7.9, 1.56, 2.53, 3.41. Again, the idea here is, this is also in presentation, we're looking to have acupuncture equivalent to usual care. Again, we don't necessarily think that acupuncture is going to be better than, because opioids and NSAIDs are quite effective. But in fact, there are many cases where opioids are not preferred in that ED setting. So again, there are some conditions where alternatives are thought to be really meritorious. And again, avoidance of opioid exposure is something that we think is really important. Going back to slide 2, we're seeing that millions of people are being exposed to opioids every year, 2.0 million last year. It really speaks to this idea of, are there instances where we can relieve pain acutely and have people avoid being exposed to opioids? And this idea would be, in 30 days later, a lot can happen, but we were actually seeing a decent decrease from where they were at their entry into the ED. Again, we publish all this work. You'll have access to these slides, so you can look at these as you like. So again, in this case, the current state is that short-term pain, the 2-point units that I mentioned, is pretty reliable. We've seen that across a number of conditions. Longer-term pain relief, which we're working on that paper, was exhibited. Again, we're really happy to see that, because does that change how the clinical team cares for a patient? So if we can demonstrate and have in the medical record this relief of pain, does that change the bolus or the delivery of medications that are provided to populations? We had some initial evidence of reducing hospital costs for pain patients who responded to IM. That namely, they had a decrease in pain of 2 units. Those patients actually were actually costing less. We have to dig into that. The hospital costs are rather tricky, and they're in certain categorical buckets. So again, more work needs to be done in that area. And these therapies are well liked by providers and patients. Again, the ED really made that very clear to us, where we've heard time and time again that ED providers really appreciated not having to rely on narcotics. In fact, one of the medical director of the ED has a quote that I love is, Jeff, I'm tired of narcotizing my patients. Can you help? And that was the kind of genesis of this whole thing, saying, we don't need to be using narcotics as much as we are in the ED, but we don't always have other choices. Please see if you can provide some insights. Now, future studies, absolutely. In fact, my team and I are currently working on a multi-site feasibility study of acupuncture in the ED, with the idea of multi-site studies are really needed to demonstrate what we saw initially in that Abbott Northwestern ED, that really nice change that was numerically equivalent. We weren't powered to do the statistics to compare them for equivalence, but the idea is That feasibility study worked great in the Abbott ED. We are pushing forward with an application, it's a UL1 application that is currently under review, to bring this to some of our BraveNet practice-based research clinics. I'll talk about BraveNet in a minute. So the idea is to collaborate amongst people you know and work well with. Thereafter, a definitive study of acupuncture ED would be the final goal. And actually the final goal would be, could we have a CMS or an insurance company actually pay for acupuncture ED? What we've heard is there's not enough time to get pre-approval for acupuncture in the ED. And so partly the goal is get more data to support the impact, both pain relief and avoidance of opioids. And we feel like we're going to have a better case to make for that petition for coverage. Multi-site studies of inpatient of integrative medicine are needed as well. Certainly, there are only a few examples of that, but the idea of, does one example in Abbott Northwestern Hospital relate to the same thing that we're seeing across the country? How do opioids, analgesics, and IM therapies work? When we controlled for opioids, we were seeing that IM therapies actually did relieve pain. So we weren't just taking credit for the opioid analgesics given. So again, and it's possible that in some conditions, would the integrative therapies magnify the impact or the analgesic effects of opioids? So again, we're not opposed to opioids, but we would like selective use where needed, and if we can actually have the least use of those possible. Longer term effects of IM on pain and anxiety going out 2 or 3 days would be really interesting just to see how that looks. And then again, more cost effectiveness research has to happen. And I'm very curious on what's happening in those patients who respond. Are we seeing some changes that we could pick up via some salivary cortisol or other options, other stress hormones changing? Collaboration is key. This was funded by a grant to me by NCCIH, but again, this is all about a team effort, of course. I want to go now into the second aspect, BraveNet, which is a practice-based research network. So again, when I talked about practice-based research, here's more along the lines of what we're thinking. However, the work at Abbott Northwestern was practice-based. It was delivery. The research was on the back end of it. It was all referrals by providers for clinical conditions. And there was no preordained dose or delivery that was expected. So it really was also practice-based. So BraveNet is the only national practice-based research network of IM in the US. Currently 15 leading integrative medicine clinics, plus 3 in the VA, which is actually very fun. Founded in 2007, it's expanded in 2 waves of enrollment from 8 initial members. Again, we're really trying to get ethnic diversity, geographic range, and people who are actively funded researchers to extend the livelihood of the PBRN. You can see this, the geographic diversity was a bit better. We've had some clinic closings or research group closings. We've lost 3 of them, and we've added 1 recently. My home institution, Connor Integrative Health Network, is the newest member of BraveNet. Definitely Northeast focused, so we'd love to see more of this map filled out with collaborating groups. There's a lot in the West, Midwest, and South would be highly desired. Definitely, these are old papers that we've published, so we can look to those. There is a value towards practice-based research, and we certainly have, I think we have now 7 or 8 papers, so these are just the 4 that I have on this slide. So the last part of the talk is going to be talking about the major effort of BraveNet over the past number of years, which is a registry called Patients Receiving Integrative Medicine Interventions Effectiveness Registry, PREMIER, spelled in our own way. We wrote a study protocol and published that a couple of years ago, and the specifics are we're conducting a prospective, non-randomized observational evaluation connected to all BraveNet clinic sites. We enroll people, and then we follow up with them at 2 months, 4 months, 6 months, and 12 months. And then we extract data from patient health records, including their services, the diagnostic codes, which tells us who they are as a patient, and the CPT code. The basic goal is to look at change of the patient-reported outcomes over time, quality of life, mood, and stress. We want to look to control for baseline characteristics, and ideally we would see, are some specific interventions differentially impacting outcomes over time? And I will get into that in a bit. This is just a real this is a delivery of the sites and the recruitment over time. You can see it just takes time. It started in 2013. We ended enrollment in 2017. And with our long-term follow-ups, we are still in the midst of that final data collection or final data delivery. We have an enrollment date, patient demographics. We use the Promise 29, which has 7 different constructs and has 4 questions per construct as our main patient-reported outcome. We are also looking at that's a typo, it's just a perceived stress scale. Also the patient activation measure, and primary care conditions and symptoms, IM services utilized, and new patient status. So probably 75 questions to 80 questions at enrollment, and a bit fewer at the end, but there is a significant amount of questions that we're asking of these participants. In this case, I'll focus on pain today. There are 4 questions on pain. How much did pain interfere with your day-to-day activities? Not at all, up to very much. How much did pain interfere with work around the home? How much did pain interfere with your ability to participate in social activities? How much did pain interfere with your household chores? So pain interference. Just basically, I'm going to go through, this is the penultimate, so this is not the final data set, but I want to give you a sense of what this looked like. And at this point, at the point that this was created, we had recruited 4,578 patients. Not all people complete 2 surveys. We matched them with EMR data, and then looking for people who have chronic pain, that is to say they self-report pain 4 or greater on a 0 to 10 scale, where 0 is no pain, 10 is maximal pain, for 3 months or longer. And we come up with a chronic pain cohort of 969 participants. Generally 51, mostly female, mostly white, college educated, insured, because this is the lower insurance categories, and generally healthy. I'd say, normal weight to slightly overweight is probably the higher categories. Briefly going through the EMR diagnoses, pain is the primary diagnosis that we're seeing. And again, they can have multiple diagnoses, so this won't equal 100, but chronic fatigue, myalgia, sleep disorder, anxiety, headache, depression, arthritis, a host of things, fibromyalgia, sciatica pain. They come to us with pain plus something else in general. This is just showing this is not up to date, but this is up to date from what I'm showing you. I'm actually presenting this at the International Congress, so I want to preserve the newest data for that, but this is very relevant data for today's purpose. Chronic pain patients, again, we do lose some people over time. That is part of practice-based research. The other part is we did not pay individuals. So were we to have paid people to complete these surveys, which is very common, the remuneration would have been over $1 million, which would have far exceeded our very careful budget. So again, that's the other part with randomized trials is oftentimes there's a hefty remuneration for participation. So we really wanted to get a sense of the altruistic behavior of individuals in a clinic as they're receiving care in the clinical setting. What are we seeing? So again, this is truly, as David Chertoff called, with warts and all. This is the real world. This is probably even more real world than most people would like, but it is the real world, and we really appreciate each and every patient's participation, because we did require a lot of questions, but we really feel like we're going to give back to them manyfold. This is a busy slide, and do forgive me, I wasn't able to make it easier. Just focus your efforts on the chronic pain cohort in red here. And what I want to show you, again, I almost just did this with numbers, but I think the visual is actually really interesting, because what I'm looking for is we have 7 different constructs on the Promise 29. We've got anxiety, depression, fatigue, sleep disturbance, pain interference, and then satisfaction in social roles and physical function. And all 5 of these to the left, better health is having a lower score. Now these are norm to the US population, so 50 should be the norm, and a standard deviation is 10. So again, 1 standard deviation, your bell curve is going to look something like this, where the most people are going to be at the mean, 1 standard deviation above and below are going to be here, and 2 here and here. So again, in this case, 56.7 designates the mean level of anxiety that the chronic pain cohort is exhibiting. So well above the national norm, because about a half standard deviation is where the clinical significant difference is for some of these conditions, or at least for the baseline designation. So higher anxiety, decent depression, fatigue is high, sleep disturbance, again, above the norm. Here's again, obviously, with the pain interference. 62, the error bars don't even come close to touching the line at 50. So again, pain interference with probably some fatigue and anxiety thrown in just for good nature. And physical function, the other one is lower. So 42 is lower. So again, we would like people to be above 50. So again, better health is going to be above the line here and below the line over here. So again, this chronic pain population is on both sides poorer and poorer than the national population. Perceived stress score, this score goes from 0 to 16. 0 is no stress, 16 is maximal stress. The national mean is 6.3, or sorry, is 4.5, and our group was 6.3, so a little above the national mean on stress. Patient activation, 100 is good, 0 is low, so you want how activated are the patients, and there are all these different levels. Level 1 is starting to take a role. Level 2 is building knowledge and confidence. Level 3 is taking action. Level 4 is maintaining behavior. You should note, 44% of our group is already at level 4, so they can't get any better. And they're at 63.8, and looking at a national norm, the PAM, they're almost right on the national norm. And you can see we have a higher proportion of people at level 1 than the national average, but pretty close on other ones. Just gives a sense of what that means. About 2 more minutes, and then I will get to some questions and answers, as well as the future state. Promise interference, so enrollment is the score here, and we're looking for delta change. So we're looking to see across time, we see about a 3.4 unit decrease. Based on published data for pain interference, the minimal important difference is anything over 2 units. So again, we're starting to see at 4 months, 6 months, and 12 months, this decrease in pain over time is reaching that clinical significance. In fact, pretty close even at 2 months. So we're seeing some pretty quick response for patients, and then pretty consistent response thereafter. So again, on our primary aim is patient-reported outcome for pain interference. Is this group finding relief? I would have to say the answer is yes. I did mention anxiety was up there as well. And in this case, the mid is 2.5. And we can see right about 12 months we're hitting that mark. And again, this is not showing exactly as it is on my slide at home. But you can see that it's decreasing over time, maybe flattening out in this 2 to 4 to 6 month period, which is interesting. But again, by 12 months, we're seeing that decrease, which is quite interesting. Perceived stress, again, a decrease right off the bat, pretty flattened out, and then about a 1 unit decrease over time. And 1/2 units is the minimal important difference or clinically important difference. So again, we're seeing some changes, but again, perhaps on that perceived stress scale, we're there at 6.3 relative to 4.5 at the average. So we're seeing them probably get closer to average, but not meeting that clinical significant level. And finally, patient activation. This is where a 4.5 unit difference is clinically significant, and we're getting to about 3 units at that very end. But you actually see here, these error bars are pretty large. So again, my intuition, again, some of our analyses are looking at, we're seeing some responders who are doing quite well in patient activation and some who are not. And we're diving into that as we speak, preparing for some presentations. The current state is chronic pain cohort in Premier reported clinically important reductions in pain interference, and some interesting, and actually what I didn't mention was anything that's below where these error bars do not cross the line is statistically significant. So again, we're getting statistically significant differences, but maybe not clinically significant across all those time points. So again, you can see even in perceived stress, all these error bars are below, so they're statistically significant, and we're seeing that at the end for patient activation. So we're seeing some nice changes. And the future state is we're looking to see, we're hoping to identify our specific therapies associated with better pain relief. And at some point, we would like to think about dosing. However, as I mentioned at the outset, dosing as confounded with insurance. So we're looking at some different strategies to account for that, because what we're interested in is the truth. And we're trying to figure out, could we provide some information to patients and providers to inform them with some more relevant information to make decisions. So my vision in the future state, and really why the passion of me being here today, and I will open this up for questions, is I would love to see practice-based research prospectively collect data across the entire consortium. I think this idea of 15 to 17 clinics is great. We got some of the kinks worked out, but with, I think we're at 60, 75, whatever the number is, of members, I would love to see open up the participation to this practice-based research option. And really the reasons are increasing diversity. I think the patient types would increase. I would like to see different age groups. I think we, in the clinic we have some that are very specific to older adults who have cardiac conditions. That skews our numbers a bit. So I think we get a better distribution of ages if we had more clinics. I think I would love to see more males involved in this research. I think it's very important. I think with Medicare, Medicaid, and other insurance possibilities changing, I would love to see with more clinics that would get a wider variety of insurance coverage, because I think that's actually one of the factors that will be really important for interpreting these data. I think we can improve our geography. I pointed out initially, the Midwest, the South and the West are underrepresented. So I'd love to see more representation by those areas. I think interventions. Chiropractic care, I believe, was only provided at one of our BraveNet sites. So I know at UH we have now 3 chiropractors, and they are very busy. And so we're practice-based research to be included in places like University Hospital, Conner Integrative Health Network. There would be a lot of chiropractic visits and chiropractic visits with Medicare. So it'd be really, really interesting to see how integrative medicine works in those environments as well. Clinic types, I love the idea of suburban, urban, rural, again, really broadening out to all the members. Now the consortium might be a bit more urban and suburban, but I think this idea of rural integrative health and medicine is something we should all be considering, especially because there might be a confound with the opioid epidemic. Namely, people in rural environments oftentimes don't have access to alternative methods or integrative methods or complementary methods to reduce pain. And so I think it behooves us to think about how do we expand what we're doing into rural environments. And finally, an increased sample size. Unfortunately, some of our analytics were constrained by the sample size. Even having 1,000 patients would seem like a lot. But when you start breaking this down based on conditions and other aspects, it can really challenge our analyses. So partly increasing to the whole consortium would allow us to really do some extraordinary analytics that would, I think, provide us with adequate data to provide patients, providers, and payers with information on possible outcomes for specific interventions and doses. So I tamed this down from what I'd love to say. I'd love to say we would love to be able to have a opportunity to think of best practice, of clinical guidelines. Again, that does put people off. So this idea of patients, providers, and payers, the 3 Ps, with information on possible outcomes for specific intervention and doses. I love the idea of being able to go to patients and say, hey, we are reliably seeing a 4-unit decrease in pain if people are receiving 4 or more acupuncture sessions for low back pain. I think that would really help us to get to the right patient at the right time for the right condition. I've overstated by 4 minutes how much time we're going to have for question and answers, but I welcome your questions and I appreciate your attention. Thank you.
Thank you, Jeff. What an informative presentation. So great. I really like your vision. Very great vision. I wish we can collaborate with consortium clinics on this. We do have one question from audience. She asked, would you be able to include clinics from Canada in BriefNet?
My envision is the consortium, and we do have some Canadian members, so I don't see any reason why not.
Okay, I hope she will reach out to you.
Okay.
And when we're waiting for other questions, I just kind of want to add my comments. I'm myself is an acupuncturist, and plus my PhD. I'm so excited about what you're presenting about the results for acupuncture in emergency room department. So I'm just wondering, what are the challenges you encountered performing acupuncture in ED? For example, do you need to get the IRB approval, like informed consent, how much time you use there? Is there any delay because of those research-related protocol?
It's a great question. So I skimmed over the feasibility study, but we have a very tight protocol. So I had the research coordinator positioned at the triage desk for many hours. I mean, I think we looked at this, it was a 7-month study. And the biggest challenge is probably just having the foresight to have enough funding to have that acupuncture and the coordinator team to be in the ED, and you may only enroll 2 people in a 4-hour session. I think the easy part was we had done some groundwork where we had relationships with our providers, and really found that a lot of the physicians, nurse practitioners, and PAs really appreciated the fact that there was something available to patients that wouldn't put them at risk for an opioid use disorder or something like that. So I think the biggest challenge was for us to have enough of a resource to be able to deploy this, but the study went really well. And so I'm really optimistic that our feasibility, multi-site feasibility, will be funded, and we'll be then able to complete that and then prepare for a nice definitive study where we include more than 3 clinics and more than 3 hospital EDs just to enroll the 1,000 or so patients we're going to need.
That'd be
but it actually went really well. And there have been a couple other groups of some folks that I helped get set up, and they didn't have quite the 89% response rate or 76% acceptance rate. They had fewer, it was more like 52%. So it's not as if every ED is every ED. So again, it's relationships and really meeting them where they are and not overstating what we can offer. Again, we are careful researchers and really try to make sure we are always focused on patient benefit and doing right by everybody.
Great, thank you. I have another one coming. Can you comment on the lack of implementation of RCTs and the national guidelines? Essentially, we have thought evidence will translate to implementation. Thank you.
Yeah, I mean, I was at that's a great question. The idea, and that speaks to that purple bubble on that second phase of research from NCCIH that I showed. I was at a 1-day workshop on implementation science that NCCIH put on. I think there's more of a push, and again, one of the program officers, Dave Clark, is very interested in implementation science. And so I think there will be more implementation. Now, again, implementation science uses randomized trials to understand the best way to implement interventions in environments. So I think there's going to be, I know there are a couple more funding announcements that are, I think, en route to foster more of this work. So I think more to come. I think the other part of your question was how do we understand what we've learned from clinical trials to develop some guidelines? And I think that is rather more challenging. And I think those guidelines, I feel like, come better from practice-based research, just because in practice-based research, one of our strengths is we're studying what's happening in the real world and the messiness of how people go into the clinic. in a randomized trial, as I mentioned before, there's so much carefulness to ensure that acupuncture is paid for by the study, the patient's not being charged for the visits, and in fact is probably remunerated for completing questionnaires. So again, the guidelines, if they're based on those three conditions, acupuncture paid for, remuneration, and no charge to patient, it might change the outcomes. It might change what we see. So I do worry about that, if I understood your second part of your question correctly. But in the first part, implementation science, I think, is definitely gaining ground at NCCIH, and I'm really happy to see that. And in fact, I'm a co-editor at the Journal of Alternative and Complementary Medicine with Ronnie Elway and Stephanie Taylor of a implementation and dissemination science research special issue. So go to JACM if you're interested in submitting an article on implementation science to that journal, that special issue this year.
Thank you, Jeff. For the time's sake, we have to wrap up. Thank you again for sharing your knowledge and the vision with us. It's such a wonderful presentation. And I would like to thank everyone for attending the session. And we will post Jeff's slides on the consortium website. You can log in to download that later. Okay, Jeff, we're going to say thank you and goodbye. Have a great day.
Thank you very much, everyone. Have a great day.